every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
Because remembering today is Sunday morning, I went to church for my service already, and then now I managed to make it here on time. And also realized today is actually, what's the importance of 28th of February today? Do you know? Apart from Sam's ASM? Yes, the Madonna Rebel tour is here. So I'm actually very thankful that you all chose Sam's ASM instead of the Madonna Rebel concert, right? Okay. So for those of you who are going, I wish you all a good concert, all right? But I've been told that for those of us, I heard this morning from the sermon which I've heard is that it may not be very good for the soul and the spirit. So for those who are going, please be warned, all right? Okay. Thank you again to the organizers for accepting my proposal. I've chosen, actually I didn't actually choose the topic history of local trauma resuscitation. I was trying to move towards the title of changing trends in trauma resuscitation. So this is what I will be sort of talking about. And I was particularly pleased because with this title, I'm able to sort of, on a personal level, revisit some of the things of the past and maybe just covering about things of the present. And I think Dr. Pa here will be covering quite a bit on management of hemorrhagic shock and some of the other stuff. So I'm just going to breeze through what has happened over the last maybe 3 decades. I remember I was a trainee actually way back in the early 80s. All right, so my talk is going to cover issues and things that has happened over the last 30 years or so. So this is the old SGH. I'm not that old, so I've never worked in that place before, all right? I don't know who has worked in this place before, and I don't think any of you have, all right, so far. So a disclaimer, you will find some products that I may be showing you. I have actually totally no connection and money from the products which I'm going to show you, all right? It's purely to illustrate a point, okay? So what kind of patient am I going to talk about? I'm going to talk about basically this kind of patient, right? Those who have, severe head injury, abdominal, pelvic, and limb injury, multiply injured patient. Okay, this is the patient I'm not going to talk about. I'm not going to talk about isolated wrist, fracture and all that. Okay, and in those old days, you can take pictures without having to ask permission. Okay, so that's one major change in trauma. These days, it's very difficult to get pictures. Okay, you got to sign 1001, you got to explain informed consent and all those stuff that goes along with it. So pictures are taken. So those days are over. Okay, so these are pictures in the past. Okay, so when you are multiply injured in Singapore in the past, so what happens? So the first point of contact usually is with EMS, right? Pre-hospital. In the old days, it was called the Rural Board, and then it became the Singapore Fire Service. I wonder any of the paramedics here work for the Singapore Fire Service. I saw some of my old friends outside, but I'm not sure if they are here in this particular lecture. I think Eng Ho here must have good memories about the Singapore Fire Service. By the way, the folks here are actually nurses with midwifery training, seconded to, the fire service to run the ambulance service. And I remember in the old days, the response time is, I don't know how much. Nowadays, 11 minutes average. In those days, but they are very efficient. Okay? Our colleagues in the old days used to do 11 runs, Eng Ho, correct, no? 11 runs a day, you know. And our paramedics now, with all the bells and whistles, and all the good stuff here, maybe 5 runs, 4 runs a day. But of course, they go there very quickly. They deliver the package on time. All right, so a big difference over the years. All right, and over the years, you know, apart from just being a nurse and a midwife, and you can staff the ambulance service, I think the ambulance service, the EMS, have gone through major changes, not just in equipment, but also in education. All right, in 1990, some way before you were born for some of you, there was a basic trauma life support that was brought to Singapore, okay, by Professor Anantaraman with the aid of ASAP, okay. So, and then after many years, it moved on to become the International Trauma Life Support. And I think in Singapore now, there's also a pre-hospital trauma life support, depending on which American entity you are working with. Of course, this is with the American College of Surgeons, and the International Trauma Life Support is actually with a chapter of the American College of Emergency Physicians. But whatever you are following, it doesn't really matter, because it brought structure and it brought science, all right, to the art of delivering trauma care in the pre-hospital setting. And if you look around the world, increasingly, advanced life support actually has been slowly creeping into EMS as well. And it begs the question, does this improve the quality and the outcomes of care? So currently, according to the Cochrane Library, who have done all these reviews, there's actually no evidence out there for trauma. There are lots of evidence out there that advanced life support for cardiac care will contribute to good outcomes, but not so much for trauma. Okay, it doesn't mean there's no. Okay, it's just that there's no evidence out there currently. All right. So when you come to the hospital, what happens in the 80s and the 90s? So some of my colleagues here will be complaining that they will have to refer, and beg individual specialty to take the patient. And this is it's a commonplace, in the past. Okay? In the past, we survived on pages. In the past, we were taught ATLS, right? How to deal with individual patients on an individual physician basis. All right? I remember attending ATLS in 1991. Okay? In the UK. And when I came back, the hospital was so happy that there are some of us now trained in ATLS. It says, wow, we are bringing, new light into trauma care, for the hospital. All right? So this is now commonplace, right? Everybody who's supposed to deal with trauma care in the hospital should be certified in ATLS. But is there real evidence out there that ATLS actually provides better quality or better outcome of care? It still remains to be seen. But obviously with ATLS, it has helped us to move, all right, from referring to individual specialty to a more integrated sort of approach now, where trauma teams are actually, multidisciplinary trauma teams are now the mainstay, all right, of providing trauma care in the hospital, all right? So much so now, in the old days, everything is learned by on-the-job training, by the way, yeah? Okay? If you don't believe me, you ask Professor Lim, the co-chairman of this organizing committee, how we learn cricothyrotomy, okay? In the old days, every patient that goes into the mortuary will have a little slit in the throat. It's either by myself or Professor Lim, all right? It's not because we perform, crico on everybody. We do it, basically for skill training purposes. Of course, you can't do it now, okay? You cannot do it at this point in time. For both ethical and moral reasons, there's no way, all right, you can do this now. In fact, right now, all my residents are trained in the skill lab. all right? They are trained to task trainers, all right, before they even encounter the very first patient, okay? Trauma teams will not be, playing out the scenario on real patients. They will be playing out in the lab simulation before they even go to the real patient. So that's how much we have changed over the years. Right? In the old days, in the airway, right, the first thing you encounter, all right, oropharyngeal, back mouth mask ventilation. Now you have some other options, all right, especially for the pre-hospital setting. And then I remember in the early 90s, when we taught BTLS, right, to our paramedics, to our ambulance officers and all that. The teaching is very simple. If you have a head injury and low GCS, you hyperventilate the patient. Okay? You back 20 times a minute. Okay? And the rationale is because your brain has a tight space, right? It's occupied by brain, blood, or CSF, right? So based on the Monroe-Kelly sort of hypothesis, if something swells after injury, your brain, something has to decrease, right? To keep everything in status quo. So if you hyperventilate, you decrease your PCO2, you decrease the blood supply going to the brain, all right? Vasoconstriction. So you maintain status quo, okay? But you know that decreasing blood supply to the brain is never a good thing, okay? So if you keep on doing that, you're actually creating a vicious cycle and you're making things worse. So right now, there's no need to hyperventilate a patient. And this was done really, in the good old days. It was standard practice, by the way. Now you try and keep the patient in normal carbia, all right? So A stands for airway. A also stands for airway plus cervical spine control. Those of you who have done all these trauma life support courses, in the good old days, sometimes you get it, sometimes you don't. Once you have a C colon, you should be very fortunate. But these days, we actually package the patient like this. Okay? And every time I see a patient packaged like this, I'm just wondering, is this a good thing or not so good thing? All right? I don't know whether you can see this little cartoon here. It says, the paramedics was trying to ask the patient, what can we do to make you a little bit more comfortable? The patient says, can you please put me back into the vehicle without the backboard and the cervical spine immobilizer and all those things? I'll generally feel a lot more comfortable. Yes, it's true. Have you tried it on before? If you have lie on the backboard, if you have lie on with a cervical spine and all that, immobilized, it can be a very uncomfortable experience. And I can tell you, a lot of trauma teams don't recognize and don't pay particular respect to that. If you lie long enough, you develop sores, you develop a lot of pressure areas and all that. And the worst thing is this: it actually may and can compromise your airway if you lie the patient this way without being able to turn the patient too much. All right. So there are issues with that, and it is still questionable whether all the this whole thing being applied on the patient actually brings about any benefits to the patient. Okay, it is still highly questionable. Right. Coming to circulation, in the old days again, when you have a problem inserting an IV to start fluids, all our junior doctors, what happens when you see a patient? Everybody likes to get vascular access. Everybody likes to take blood. All right? The more tubes, the better. All right? Everybody likes to start fluids. And I think I'll leave the scientific part to Michael later on to talk about. Are you going to talk about fluids? Oh, very briefly. Okay. He will do that. All right? So everybody likes to do the vascular access. It is nice. All right? It doesn't take a lot of thinking, just manual work, right? And in the old days, if you have a problem with vascular access, what do? We do a venous cut down. Yes. That means make a slit at the long saphenous vein in around the front of the medial malleolus, and you dissect, hook up the vein, tie it off one end, and then you insert a cannula there. All right. But of course, in these days, different, right? Everything is mechanical. Nowadays, got the man with the drill. Okay. So for those with very, very problematic one, you use a big drill. If you want to start small and more, painless, you do the small one, all right? And then now we also have what? Ultrasound-guided peripheral IV access. Okay, now we have a lot more tools. So in the old days, just imagine, we have to do all that. So for the brave, they will go about more proximal. For those who are not so brave, they will go down to the long saphenous vein. Okay? Hey, by the way, cut down is no longer in the American Board of Emergency Medicine curriculum for procedures. I think my residents will know that. All right? Now it's been moved off the curriculum already. I'm not sure whether they are still teaching it for ATLS. Anybody who knows ATLS? Optional. Right? So you know where is it heading? Slowly but surely, it may not be obsolete, but maybe not emphasized. Because it's a skill that still can be used. Okay, even. Fluids. Okay. If you go back to my ATLS course in 1991, standard, 2 large IV, in the forearm, 2 liters of crystalloid goes in, and then you should be very happy with yourself. And then you look at it, whether you are responder, transient responder, and all those things. All right. Of course, my favorite fluid is not this one. My favorite fluid is actually this one. Okay. But as you know, we have now moved away from those concepts. All right. Right now, if you look at the latest ATLS guideline, is maybe 1 liter. You better be a bit more judicious. All right. If you have definitely evidence of loss of blood and you are in, grade 3 shock or whatever it is, blood really is the answer. And I think we have learned a lot, from disciplines like OBGYN who does massive transfusion whenever they get postpartum hemorrhage, for their patients. So because of all those lessons, and also lessons from the war in Iraq and Afghanistan, I think the American experience has been or the Australian experience has been very rich here, where we have shown that, blood is probably the best replacement for blood loss. And not just blood, but also replacement in terms of platelets, all right, and plasma in certain combination is now the mainstay of fluid replacement, all right? So this study talks about a 1:1:1 or 1:1:2, all right? Whether more blood or, a little bit more plasma and platelet is important. But the essence is this. The essence really is no longer on units of packed cells, but bundled together, all right? Blood and blood products bundled together. So in the old days, you used to have to beg, okay? If you're the MO, you have to beg blood transfusion service to give you blood, okay? They want to know where is the bleeding coming from, what's the HB and all that. I mean, when the guy is bleeding, you really don't want to answer those questions. These days, we have the massive blood transfusion protocol to help us. And in the package, right, includes what? Yeah, transexamic exit, okay? I think the crash trials have proven that transexamic exit is actually very useful as an anti-fibrinolytic agent, okay, to prevent lysis of clot and all that, all right? So now it's part and parcel of our massive transfusion protocol. The thing about tranexamic acid is that it should be given as early as possible, okay? I'm just looking forward to the day where maybe it will find its way into the EMS service, where it will be given to bleeding patients. Now, whether this has a positive effect, all right, on bleeding in the brain after traumatic brain injury, the evidence is still not available yet. Okay, we are still waiting for trials There are 2 ongoing trials now. We are still eagerly awaiting for results. Bleeding is obviously a bad thing. So I got 5 more minutes. Okay, very quickly. Run through 30 years in 5 minutes is quite a challenge. Anyway, how many of you have seen this before? It's called the pneumatic anti-shock. Once you put up your hands, your age is it's a giveaway, right? Okay. So in the old days, when you have pelvic or abdominal, intra-abdominal bleeding, we apply what is called the pneumatic anti-shock garment, or what we call the mask suit in short. Okay. It has 2 components, the lower limb and the abdo-pelvic component. All right. So you are bleeding in the lower limb or whatever it is, you just apply the lower limb component. You step on this pump here, it pumps up. So what it does is that it creates a tamponade effect. It also squeezes blood from the lower limbs, if you are in shock, towards the heart. Okay? That's what it does. But once you put on the abdomen pelvic component, you have lost access to the abdomen. What it means is this: you have to go to the operating theater, you probably have to do a laparotomy. There's nothing else that can be. Because once you open, the patient exsanguinates. All right? But not proven to be useful. So this is already history, Okay? If you still have it in your department somewhere, I'm not sure what is it for. It may be of sentimental value. That's why I don't have. I'm so sad I didn't have a picture of it, because we actually do have one in our old department previously, right? So we are now into the age of what? Pelvic binders. All right. Whether is it commercial or whatever, it has been shown to be able to decrease the pelvic volume, right? Okay. It can be simple. It can be sophisticated. Doesn't really matter. The other thing about bleeding is this. Okay. In the old days, all right, everybody who is a first aid instructor and in the hospital will tell you, do not use a tourniquet. It was in the ATOS guidelines as well. Okay. But now different. Now ATOS says that tourniquet are useful. No. Okay. All right. Tourniquet has made a big comeback. Okay. So nowadays, the soldiers don't go to war unless they have a tourniquet. Okay. Secondly is this, you realize before they go to war, right, they go to army supply shop, they buy additional tourniquet, and they put it as part of their personal kit. Okay? Alright? So that's how important tourniquets are. If you're going to read the literature, the recent Paris attacks, the 4 places, the concert hall and all that, right? The SAMU, came back without their belts. Okay? Because they used their belt as tourniquet. Okay? So, carry some, alright? Okay, in interest of time, I'm just going to rush through. Then, of course, the other thing is, if you cannot tie off a bleeding vessel, you may have to do something else. You may have to pour something in, all right? So I mean, if you have done the first aid before, right, right? Direct pressure is the first step, all right? Indirect pressure is the second step. You compress the artery, right, that supplies that side. Now, if you can't compress and you can't apply direct pressure, the next thing, of course, is you pour some hemostatics inside. Or you can now even have something like this product where you inject sponge, like Marocel, all right? Soaks up, creates a clot, and stops the bleeding. All right? All right? In those days, old days, don't have, mask suit, direct pressure, and that's all you have. And of course, even better these days, if you are bleeding in the abdomen or in other parts, in the pelvis or whatever, you can actually insert endovascularly balloons that will occlude the aorta and bleeding and all that. I'm not going to cover this too much. This one I must tell you, okay? Last time we used to diagnose intra-abdominal bleeding by doing what we call a 4-quadrant tap. So only one person is nodding the head. That tells you how old she is. We used to get a very large ball needle with a syringe, and we 4-quadrant, 2 lower and 2 upper, try and aspirate blood. Once you have blood, you go to the OT. All right? And then, of course, we have what we call the diagnostic peritoneal lavage, now slowly going out of fashion. All right? And now we rely mainly on ultrasound, totally non-invasive to get things done. Okay? Before they cut off the power to my talk, I must tell you this, okay? I must tell you this, that X-ray comes after ABC, all right? And X-ray requires the lowest life form in the resuscitation room to wear a lead shield, all right? What is that for? It's actually to pull down your arm so that you can have access to the C7 vertebrae during your cross-table lateral C-spine. But now, it is all about CT scan, right? And they even talk about what, no? CT scan during primary survey, you know. Okay? Patient comes in, put into the scanner, while you are resuscitating, the scanner will do its job, alright? So in about 2 minutes, you can get an entire body scan from head all the way to toe, with no regards to the radiation dose, alright? So I'm going to just come to my second last slide because she's holding the overrun placard here. Yes, okay, we often look for new diagnostics and new therapy in trauma resuscitation. Okay, this is the new SGH, by the way. It's going to come out in 2030. I'll probably be using it and not working in it. All right, but don't forget that for trauma, really, the prevention is key. Okay, all right. So prevention is key. Whether is it jumping off the bridge and all that, is something that we really need to look into, apart from just diagnostics and therapeutics. All right. So thank you for the time. I know I've overrun by 3 minutes only. All right. I hope you enjoyed this conference. For those of you who still have questions, maybe we can ask it, at the end of the whole session. Thank you very much.